Now our next speaker is Dr. Christine Long, Assistant Professor of Surgery, Department of Surgery, Section of Endocrine Surgery, University of Wisconsin, USA. And she will discuss 2 points. The first point is thyroid cancer, focusing on the newest 80 guidelines with lobotomy only for cancer. The second point is parathyroid disease.
Yes, thank you very much. I'll echo all of my colleagues who have already spoken today. I greatly appreciate the opportunity to be here today and talk with you all about the things that I spend the majority of my time doing, which is endocrine surgery in the neck. And both talks that I'll give in this session are going to talk about some conundrums that we're facing with how we treat some of our patients with these unique diseases. And the first talk I'd like to give is about thyroid lobectomy for papillary thyroid cancer. I have no disclosures or conflicts of interest. In the United States, at least right now, we're dealing with kind of an onslaught of papillary thyroid cancer. We see over 60,000 new cases every year. Over 90% of those are well differentiated, often found very early, and often found incidentally. We see a lot of patients coming that have gotten imaging for trauma or for other reasons, and oh, you know, surprise, we have a small thyroid nodule. So then they come to us after they've been biopsied and say, oh, we have a thyroid cancer, what are we going to do? The incidence is increasing from year to year. We're up to about 6 to 7% increase each year from 2005 through 2009. The question has become, is this really an increase in detection, or are we actually having an increase in the incidence of cancer? Fortunately for those of us who operate on this disease frequently, most of these patients have a very good prognosis. Less than 10% of patients with well-differentiated local regional disease of papillary thyroid cancer will die from their disease, but recurrence of this disease remains a major challenge for those of us who operate in the neck. The majority of thyroid cancer comes from papillary and follicular cells, and that is papillary thyroid cancer, follicular thyroid cancer, or Hürthle cell carcinoma. And that's what we're going to focus on essentially with this talk. I'm not going to deal with medullary thyroid cancer or anaplastic, which have a completely different disease profile and should be treated appropriately aggressive. For papillary thyroid cancer, that comprises probably about 90% of all the thyroid carcinoma that we see. It has a high incidence of lymph node metastases, up to 85% in some reported studies, but it fortunately has a 95% 10-year survival rate. Follicular and Hürthle cell are slightly more aggressive, but still nowhere near the aggressiveness we see in something like medullary or anaplastic. So when I'm talking with patients who come to see me with, say, a 1.5 centimeter papillary thyroid cancer, I tell them that we're going to approach this with a 3-pronged treatment approach. First arm is surgery. Although there are some places in the world that are now doing observational studies for papillary thyroid cancers that are under a centimeter, we don't have great, really long-term data on what happens with those patients that undergo observation. And for most of us who treat these patients, they ultimately end up being more of what we call delayed intervention. Many of them will progress to needing surgery. So for the majority of patients who see me in the clinic, surgery is the initial recommendation for their thyroid cancer. If they need it, we suggest radioactive iodine, and we'll get into a little bit about who actually needs radioactive iodine in a few moments. And then finally, the third arm of that approach is called TSH suppression, and that's where we give patients who've had a total thyroidectomy more thyroid hormones so that they're actually not secreting TSH and stimulating any stray thyroid cells. And the conversation I have with these patients is, you can have a stray cancer cell that stays in your neck, that survives surgery, that survives radioactive iodine, and it can hang out there in your neck as long as it's not growing or causing problems. We want the punishment to fit the crime. So the goals of our initial therapy: complete surgical resection of the clinically evident disease, minimizing treatment and disease-related morbidity, and that's the major impetus for the guideline revision we're going to talk about momentarily. We want to permit accurate staging so we can educate our patients and deploy treatment modalities as best indicated. We want to facilitate post-operative treatment with radioactive iodine for patients who need that. We want to permit accurate long-term surveillance. So what's the best way to do that? Is it involving removing more thyroid tissue or lymph nodes to eliminate them from clouding our picture later? We want to minimize the risk of recurrence and metastatic spread. So when we're looking at our new increase in thyroid cancer diagnosis, we also have to examine the fact that although the thyroid cancer diagnoses are on the rise, the deaths from thyroid cancer remain flat. So that's where we begin to start to question, is this overdiagnosis? And this is a problem that we certainly see in the United States. So how do we define overdiagnosis? When we look at this figure, if we look at the figure on the left, the number of new cancers, new diagnoses, and deaths are parallel. They're both increasing. That suggests a true increase in the amount of cancer that we're seeing in the population. When we look at the figure on the right, we see an increase in new diagnoses, but the deaths remain flat, meaning we're detecting clinically irrelevant cancers, and this is overdiagnosis. And what does overdiagnosis lead to? It leads to overtreatment. So what do we need? When we're talking about thyroid cancer, do we need an atom bomb? Or do we need a sniper bullet? What's the appropriate way to treat these small, low-risk cancers? So the debate became, what was the appropriate extent of surgery? And in 2015, the American Thyroid Associations revised their guidelines to say that if a documented thyroid cancer, a papillary thyroid cancer, was less than 1 centimeter, a thyroid lobectomy was completely appropriate for treatment unless there was a clear indication to take out the other half of your thyroid gland. And the impetus for this is that it allows an overwhelming majority of patients who are euthyroid to remain off of thyroid hormone medication. That is a huge bonus for most of the patients that come to see me. Their biggest concern is ending up on thyroid hormone for the rest of their life. If the documented cancer is between 1 and 4 centimeters, the initial procedure can be a lobectomy or a total thyroidectomy, and we'll talk about who goes into what category here in just a minute. However, if the documented cancer is over 4 centimeters, if there's clear evidence of extrathyroidal extension or clinically positive lymph nodes, the guidelines still recommend that we perform a total thyroidectomy for those patients. So some of the things that we factor into our treatment decision for lobectomy, if they have clear unilateral disease, that's a good candidate for a lobectomy. No aggressive features, so no extrathyroidal extension, no obvious clinically positive nodes. If they're euthyroid, if they're not already on medication right now, they have no adenopathy, they can reliably be followed, and we'll talk about some of those challenges for follow-up momentarily as well. And if it's the patient's preference, a tremendous amount of patient education is necessary for how we're going to treat their thyroid cancer. So who does better with a total thyroidectomy? Anybody who has contralateral nodules. We have to raise the discussion with these patients that no matter what, if we're leaving thyroid tissue behind that has nodularity to it, that's going to need to be followed, potentially biopsied, and potentially taken out in the future. Many of those patients do not want that continued follow-up. If they're already thyroid hormone dependent, we don't have a great reason to say we should leave thyroid tissue behind. That will often cloud our follow-up and not allow us to differentiate on ultrasound. If there's a new nodule, if there's evidence of recurrent cancer, what do we do for that? If we suspect this is an aggressive cancer, obvious extrathyroidal extension, unclear borders between critical structures in the neck, and again, patient preference. It's a fair number of patients who come to see me who simply say, I just want the whole thing out. I want confidence that all of the cancer is gone. I don't care if I have to take thyroid hormone for the rest of my life. And as long as we go into that with a very open discussion of risks and benefits, most patients do very well with that. So this is the critical figure from the ATA guidelines that talks about risk of recurrence. And that's what we're always educating our patients on, is the risk of recurrence. It's not the risk of dying from your disease. It's what can we do to minimize you needing an additional surgery or an additional intervention in your future, because papillary thyroid cancer, most of the time, is in no way going to be your life-limiting disease. So how do we make this the easiest long-term road for you and me as a surgeon? So what are the challenges with this? The biggest challenge we've encountered as we've done more lobectomies for thyroid cancer is postoperative surveillance. Patients always want to know, is it back? Did we get it all out? What do we need to do next? So the only way we can survey somebody if they still have half of their thyroid in place is essentially ultrasound. So you're looking for structural disease, because thyroglobulin, which we use as our detector of biochemical disease, is completely unreliable when you have half of normal thyroid in place. So unless you have access to very high quality ultrasound, or you yourself are comfortable performing that, it's incredibly difficult to follow a patient who still has half their thyroid. What about loss to follow-up? What is the optimal length of follow-up? How long do we keep patients around who say have had a lobectomy for a 1.1 centimeter thyroid cancer and they're 22? Do I want to see them every 6 months in the office for 40 years? Because we know thyroid cancer can recur that far down the line. What about identifying, or more importantly, missing patients with aggressive disease? This is where we think we may have a critical role for molecular testing to try to identify some of those more aggressive or bad actor cancers earlier on preoperatively rather than postoperatively on histology, and treat those appropriately aggressively up front. So in general, thyroid cancer tends to swing about every 10 years, and it's just like a big pendulum. We went from anyone with a documented thyroid cancer received a total thyroidectomy, central neck lymph node dissection, and radioactive iodine, and now we're all the way on the opposite end of the spectrum of, if it's under a centimeter, we're not even going to take it out. So I think the answer lies somewhere in the middle. We want to make sure that we are appropriately aggressive, and for many patients that does mean performing a thyroid lobectomy alone. However, figuring out the best way to implicate that in our clinical practice is still a little bit muddy, so I think we don't have a great answer for that. And with that, I'll stop on thyroid and answer any questions that you have, unless you'd rather me go straight into parathyroid.
I want to ask you what about the heart cell carcinoma? There are controversy actually between the World Health and Data and the Army Strong Institute of Thyroid Surgeons.
So I think you're absolutely right. Hürthle cell and follicular is certainly less clear, although there is some data that's coming out suggesting that we can treat them the same way we're treating papillary, and that for many of those patients, if they're under 4 centimeters, we can consider a lobectomy appropriate treatment. But so much of that relates back to what we talked about earlier in patient preference and patient choice. Not all patients will be candidates for this. If we know they're not going to follow up, if we clinically, intraoperatively are concerned, then I think we have to be more aggressive surgically for sure.
Thank you.
I think the type of thyroidectomy is still a matter of controversy, even for simple nodular goiter. Is to do total, is to do partial, but Dr. Han.
Yes. How on needle biopsy can you swear that it is only papillary, not papillary follicular? This is the first question. The second question, you said less than 1 centimeter we do lobectomy, except if there are proper indications to remove the contralateral lobe. And the third question, what about the tall cells in cancer thyroid?
Okay, so you're absolutely right. You can't swear that it's not follicular or Hürthle cell or even follicular variant of papillary thyroid cancer. So I think that may be where molecular testing starts to play a role. We are still, even in the United States, having trouble figuring out what's the right application of molecular testing, who should get it, will insurance cover it, how do we provide that, and how do we move forward with that information. But I think that's where we're headed. And I think I would say the same thing for the follicular and Hürthle cell. You know, I think for me, at least in my practice, it often comes down to patient decision making as to who chooses what. And one of my partners at the University of Wisconsin is doing some very exciting research on how patients actually make those decisions. How much of it is determined by the surgeon and what they tell the patient, or what the patient already knows, or what their biggest concern is. Is there a fear in the patient's mind of, get it out, I don't want any cancer left behind, do more aggressive surgery, even if it's not indicated? Or are they of the mentality, I want the least invasive approach possible, I'll deal with recurrence if it happens, I don't want to be on thyroid hormones. So I think it's hard to know.
Dr. Medhat, I think time is over and we will take this question on.
Okay.
If you get a patient in the clinic after a right lobectomy, for example, for 2 centimeters, well-differentiated papillary thyroid cancer, and the surgeon discovered the pathology after leaving the hospital, the patient. Mm-hmm. The safety margin on the isthmus is normal, is negative, and he didn't dissect, of course, the central node. What to do next?
So if it's only a 2 centimeter cancer,
yes,
and the margins are negative,
yes,
then the lobectomy should be enough.
Okay.
Yeah.
You don't have to open it again.
No, you do not have to go back in. The reason that I would say this, the reason you go back in is if you find clinically positive nodes on your ultrasound. Yeah. Although I will tell you, with this controversy, as we're doing more and more lobectomies, more and more surgeons are starting to say we should do a lobectomy with an ipsilateral central neck dissection, because you're right, you don't want to go back into that compartment that you've already been in. Finding the nerve, protecting the parathyroids in a reoperative field is not fun for anyone. So several surgeons that I work with and in my area are being much more aggressive as far as prophylactic ipsilateral neck dissections.
Well, this is the teaching of memorial sloan kettering cancer for the
Yep.
last 4 years.
Yep.
Ali.
Okay.
Put in mind that papillary thyroid carcinoma is a multifocal disease. Put in mind with lobectomy, you can't detect the recurrence by tumor marker, either thyroglobulin or anti-thyroglobulin. Put in mind by lobectomy, there is no rule of radioactive iodine
Exactly.
as a treatment post-operative. So in my opinion, at least for papillary thyroid cancer, total thyroid.
And that's a lot of people feel that way because you're right. You will never know if you have multifocal disease, but what we're trying to differentiate is clinically relevant. So people could have microcarcinoma in their remaining lobe and it may never become relevant. If it does, we have to deal with a completion thyroidectomy, and that's something that we all counsel our patients on. Those who choose lobectomy, we're very aggressive about explaining to them, you may need a completion sooner rather than later, for sure. Okay, so we're going to stray a little bit from the thyroid, but not out of the neck, and we'll talk a little bit about primary hyperparathyroidism, which is probably my favorite topic to talk about because contrary to most endocrine surgeons who probably have about a 70% thyroid, 30% parathyroid practice, our practice at the University of Wisconsin is about 75% parathyroid disease, 25% thyroid. So for background in primary hyperparathyroidism, we see about 100,000 new cases a year in the United States. I think all of those are in Wisconsin because that seems to be all we do. It's about 0.5 to 1% of the general population reported, and it's more common in the elderly, up to about 2% of patients. The literature reports it at a female 2-to-1 ratio, but we don't necessarily think that that's true. A lot of men have this disease, very few get diagnosed with it. So the parathyroid glands are our little rice-sized grain of rice glands right behind the thyroid. The most common clinical presentation of this is a high calcium with an abnormally high PTH that's found incidentally on lab work. Most patients who come to see me for primary hyperparathyroidism say, I have no idea why I'm here. Somebody told me I needed to see you. That's often diagnosed just incidentally on blood work. About 10% of our patients come to us because they have kidney stones, and our nephrologists or urologists were cognizant enough to send a calcium and send a PTH. We argue that any patient with a kidney stone should have a calcium and a PTH sent because a large proportion of those will be diagnosed with primary hyperparathyroidism. Osteoporosis on bone mineral density testing is an increasing presentation in our clinic. Our bone doctors have done a fantastic job of recognizing that anyone with osteoporosis or osteopenia and a mildly elevated calcium should probably see us. There is a tremendous incidence of mild foregland hyperplasia. Unfortunately for us, about 90% of patients who are labeled as asymptomatic actually have pretty significant symptoms that are probably related to their hyperparathyroidism. My counseling in patients typically goes like this. I can't guarantee that any of these symptoms you've circled on this little sheet are related to hyperparathyroidism, but they might be, and they might get better after surgery. If anything gets better in the next 2 weeks, we'll take credit for it. However, we also tell them that we can't guarantee any particular symptom is going to get better. Now, the asymptomatic patients can have any of these particular symptoms that most people have chalked up to being some other disease process. The most common things we see are some bone loss, some abdominal pain, memory loss and concentration problems. The neuropsychiatric symptoms are a tremendous percentage of our patient population, and the neuromuscular symptoms, fatigue, myalgias, muscle weakness. I can't tell you the percentage of patients we treat for primary hyperparathyroidism that also carry a diagnosis of fibromyalgia. And oftentimes, many of their symptoms resolve almost completely after parathyroid surgery. So the treatment options for parathyroid disease. Technically, we do talk about observation as a treatment option. There's about a 25 to 60% chance of that disease progressing at 10 years and becoming more pronounced with their hypercalcemia. If someone truly chooses not to have surgery, we highly recommend they stay hydrated, they avoid thiazide diuretics, but importantly, they should have a normal calcium intake. A knee-jerk reaction of a lot of physicians when they see hypercalcemia is to tell patients to stop taking calcium, and that actually exacerbates the disease process. So we want you to get a normal calcium intake to try to help the bones as much as we can, since we're not going to treat the disease. Medical therapy for primary hyperparathyroidism is not particularly recommended. You can use estrogens or bisphosphonates for osteoporosis. In extreme cases of surgically refractory disease, cinacalcet is an option. However, it's extraordinarily expensive and hard for patients to get. So surgery is obviously the ideal treatment for primary hyperparathyroidism. When it's done properly, 95 to 98% long-term cure rate, and patients do very well from this. In the literature, we report about 85% single adenoma disease, about 15% multi-gland disease. We also think that's inaccurate just because it's a referral bias. Who actually makes it to a surgeon? The patients with really significant disease. Mild hypercalcemia or even normocalcemic hyperparathyroidism rarely makes it to a surgeon. So how do we make this diagnosis? We look for three things: a high normal to a grossly elevated serum calcium. And for our range in the United States, that can be 8.4 to 10.2 is our normal range. If somebody has a calcium persistently of 10, 10.1, we start to consider that might actually be disease. Occasionally we see people that are as high as 13, 14, 15, but those are the rare cases for us. We also look for a high normal or a non-suppressed parathyroid hormone. So the critical thing here is, even if the calcium is elevated and the parathyroid hormone is high normal, but still technically in the normal range, that's disease. If your parathyroid glands are responding as they should to hypercalcemia, your PTH should be almost in the single digits, almost undetectable. And we've argued more than once with our hospital that we'd like them to take a normal reference range away from the parathyroid hormone report. Because you can't interpret parathyroid hormone by itself. You have to look at it in relation to the calcium at the exact same time. And then the last thing we look at is there anything else that could be causing this? So what are our secondary causes of hyperparathyroidism? In the United States, most commonly, it's hydrochlorothiazide, which is frequently prescribed for hypertension. Occasionally, it's lithium. And then for our parathyroid elevation, sometimes it's renal insufficiency, and frequently, it's vitamin D deficiency. Everyone that lives in the northern half of the United States, which is where I now live, has some element of vitamin D deficiency for sure. So if we have one of those secondary causes or potentially reversible causes, that's the first thing we try to eliminate. Many patients, however, even if we stop their HCTZ, even if we correct their vitamin D, still have evidence of hyperparathyroidism. So the role of imaging in hyperparathyroidism is something that's frequently discussed, and we spend a lot of time talking about this with our students and trainees. Imaging, while incredibly helpful for surgical planning, has no role in the diagnosis of primary hyperparathyroidism. Unfortunately, a lot of referring providers will suspect primary hyperparathyroidism, get a sestamibi scan that's read as negative, and not send us the patient. And so many of those patients have hyperparathyroidism. So the imaging shouldn't be used to make the diagnosis. It is a biochemical diagnosis. If you think they have the disease, send them to a surgeon and let us choose the imaging that we'd like to do. This is from one of our recent in-clinic ultrasounds where, fortunately, the patient came with no imaging. We performed an ultrasound in the middle of clinic and found a beautiful right inferior parathyroid adenoma. That was the only imaging we had to get. And that patient went to surgery and did beautifully. There was one of our specimens, a nice example of a single parathyroid adenoma. When they're beautiful like that, it's one of the most gratifying cases you can do. Unfortunately, parathyroid disease does not always present that way. So the original guidelines for parathyroidectomy included a serum calcium that's a full milligram above the upper limit of normal. So if I said our range is 8.4 to 10.2, you'd have to have essentially 11.2 or higher to meet the NIH consensus guidelines. If you have kidney stones, you meet that diagnosis. If you have documented kidney dysfunction, or if you have clear osteoporosis. And originally when this was written, it was osteoporosis, not osteopenia, not any evidence of bone loss, but pretty significant bone loss, or a fragility fracture, which automatically upstages you to osteoporosis, or an age under 50. And then adequate follow-up if adequate follow-up was not possible or desired. What's the problem with this? This ignores all of the patients with those subjective symptoms, elderly patients, and those with incredibly mild disease, all of whom can tremendously benefit from parathyroid surgery. Now, do we see symptomatic improvement? Of course we do. Why else would we be continuing to do this surgery? So the preoperative frequency of symptoms in patients with hyperparathyroidism, and this is a list of many of the symptoms that we ask each patient about during our visits. 96% noted fatigue. 83% had memory problems. 79% noted irritability, or their significant other reported irritability, because most people don't notice that about themselves. 73% depression, 66% polydipsia, 64% dyspepsia, 43% nausea and vomiting, and these are significant symptoms that can get better. Importantly though, the symptoms do not correlate with the lab abnormalities. So somebody with clinically significant symptom disease may have very mild biochemical elevation. It's still disease, and sometimes these patients benefit the most from surgical intervention, but they're the least likely to actually make it to us. So are these changes real? These are very, non-specific constitutional symptoms. How do we know that the patients, it's not just a placebo effect? Well, we compared that and compared a group of hyperparathyroid patients to a group of patients who had thyroidectomy. So essentially the same surgical manipulation, just not taking out the parathyroids. And lo and behold, the parathyroid patients across the board, significant improvement in their symptoms, while essentially little to no change in the thyroid patients. And statistically very significant, particularly with fatigue, muscle aches, back pain, polydipsia, polyuria, nocturia, and memory loss, which are some of the most common things that we see. So we've got great data that supports documented improvement in quality of life, bone health, GERD and heartburn, insomnia, but unfortunately many patients just don't make it to us. I already kind of alluded to this in the fact that we studied our group of patients in our hospital system. Only 20% of patients with hypercalcemia were ever offered surgical referral. That's a tremendous mismatch. The diagnosis was missed up to 40% of patients, even when both calcium and parathyroid hormone were clearly elevated. And the most frustrating thing for me is that these patients are often told by a non-surgeon that there's no benefit to surgery. They assume that the hypercalcemia is from other causes, and that's incredibly frustrating for us. We've done a tremendous amount of work educating our primary care providers and our bone doctors and our endocrinologists, and I'm very fortunate that I work in an institution where they do recognize this. Most surgeons probably do not have that great of a relationship or have primary providers that recognize this. I've met with rural surgeons from middle of nowhere Wisconsin who send us patients occasionally for thyroid disease, and I had one surgeon who had been in practice for 30 years and he said, I've never seen this disease. I said, I guarantee you have. It's out there. You just maybe don't recognize it. Unfortunately, again, negative imaging tremendously influences surgical referral. It does not make a diagnosis. People think that it does because the report says no parathyroid adenoma identified. That does not mean they don't have primary hyperparathyroidism. So we say, please send them to us. The diagnosis critically is biochemical. We also look at some of the non-traditional disease profiles that are very rarely recognized. Obviously, classic PHPT, easy to recognize. High calcium, high PTH. Check, you've got disease. Normal calcemic. Normal calcium, but a really elevated PTH. Probably disease, after you've ruled out your secondary causes. What about the opposite? High calcium, but a non-suppressed PTH. Also probably disease, but may require a little more evaluation. And again, that's where sending someone to a high-volume endocrine surgeon can be extraordinarily helpful. Minimally invasive parathyroidectomy is all the rage these days. We use the intraoperative PTH testing when we have a target on imaging. It should fall within 2 to 3 minutes. It's 95% accurate at predicting cure. However, not all patients have an adenoma. Many patients have foregland disease, and PTH has no role really in that. So, in conclusion, I think parathyroid disease is a very exciting, very nuanced surgical specialty. I hope more and more patients continue to see the benefit of surgery, and I'm happy to take your questions on this disease.
We are late with 30 minutes.
Yes?
We are late 30 minutes. Please, 1 or 2 questions only. Dr. Ali.
Most of the cases now all over the world are asymptomatic. And the problem also is all with the normal calcium with hyperhormone or the reverse. But normal calcium with vitamin D deficiency and hyperhormone, you have tests for bone destruction and bone formation. The glomerular filtration rate, if affected, it is secondary, it's not primary. Calcium above 14, you cannot delay surgery because it's fatal. And again, imaging at all endocrine surgery of no value, you have to go to isotopes.
Yep.
I have 2 points, and I'm waiting to your comment.
Okay.
It has been reported that the initial manifestation of hyperparathyroidism is the absorption of lamina dura of 2 sockets. This is 1 point. The second point, Instead to give estrogen, or particularly for males, you give tamoxifen, because the tamoxifen having agonist and antagonist action. Antagonist action on the estrogen receptor of the breast, but agonist action by increase the deposition of calcium in the bone, and so we can avoid the side effect of giving estrogen to a male. I agree with you that when the imaging study is negative, we have to depend upon the biochemical diagnosis, because it may be a hyperplasia of parathyroid and not thyroid adenoma.
Absolutely. We see hyperplasia so frequently. And we see a lot of patients actually who come back, from surgeries 5-10 years ago, when we used to define the PTH cure being less, and they have now recurrent disease. And we think a lot of that was actually just missed hyperplasia to begin with. So, yes.
Thank you, Christine, for
Thank you.
participating in this meeting, and we
Thank you for
move
having
to
me.
the next session.